right. Good afternoon, everyone, and welcome. We are so glad to have you here with us today on what I'm sure will be an eye-opening and very powerful discussion today. My name is October Boyles, and I'll be hosting today's webinar featuring Don Morrison. He is an MSWLCSW, and he is a very compassionate clinician. He's an expert. He's worked extensively with individuals and families that have been affected by personality disorders. And today he's going to help us understand narcissistic personality disorder, how it develops, how it shows up in relationships, and most importantly, how to support those people who've been impacted by it. So whether you're a clinician, if you're a student, if you're someone intending for personal growth, you are absolutely in the right place today. And Don has a lot of experience. We have actually worked together in the past for a very long time. He has inpatient, outpatient.
Yes, we have.
You have lots of experiences. So before we dive in, I want to get a sense of our amazing audience today. So if you could drop in the chat, if you don't mind, where you're joining from, and if you feel comfortable, just your discipline, because we love seeing a wide range of cities and states represented here. So
absolutely. No, thank you for that wonderful introduction, October. It's good to be here with everybody today. And October knows I love to do this too. When you guys are like, they saying where you're from. Oh, I'm seeing NYC is in the house. Oh, goodness. Good to have you guys. Yes, Las Vegas. Welcome. And also tell us some good news. I know there's a lot of not so good news going on in the world, and please share some good news with us today. And we could start off our webinar with some good stuff. I know y'all are doing some wonderful things out there in your communities, and we want to hear the good news. And welcome, Lafayette, Indiana. Excuse me, I can't talk right today. Riverside, California, welcome. Yes, and share some good news. Give me some good news, no doubt. And October said we're going to take a deeper dive into narcissistic personality disorder today, looking at it through a DSM-5 diagnostic lens here too. We'll look at the diagnostic criteria and prevalence. We'll talk about, thank you, October, for the learning objectives here, talking about narcissistic abuse too, what that means, because that does go hand in hand with folks who are dealing with clients living with narcissistic personality disorder, and also focusing on assessment. Like, what are we really looking for? What are some of the comorbidities that go along with this particular diagnosis? And then moving more into the therapeutic aspect of things, like okay, we know, if we know what narcissistic personality disorder is all about, then how do we deal with it? What are some of the things we need to do to navigate it? And also looking at it from a treatment planning perspective. And October will absolutely go into how ICANotes and their wonderful electronic medical record platform would really be able to assist with making documentation that is neutral and behavior-based, as we say here in our learning objectives. Shall we launch right into it then? Next slide, please, October. And yeah, I see Lisa Richmond. Welcome, social worker in New Orleans. We got fall weather. That is great. That is great. We've had a lot of rain here in North Carolina here recently, but I think the sunshine's coming out today and it's looking great. No doubt. No doubt. Thank everyone for being here, and let's just launch right into it, shall we? So what we mean, and sometimes don't mean, when we say narcissistic abuse. And I think anytime we mention that concept of narcissistic abuse, it really, we would be remiss to not discuss what narcissistic personality disorder looks like clinically too. As y'all are probably aware of, narcissistic abuse is indeed a form of emotional abuse. And as clinicians, we all know too that emotional abuse carries such a heavy weight and has such a negative impact on our clients too, just as physical abuse does. That emotional and mental abuse really does pack quite the wallop, especially when trying to navigate dealing with folks with narcissistic personality disorder. The term narcissism, if we could, bear with me a little bit, if we could, when you hear the word narcissism, let's do some good old Sigmund Freud free association stuff here, please. When you hear the word narcissism, what is the first thing that pops into your brain? I would love to hear some feedback from y'all on what you think about when you hear the term narcissism. We also know too that narcissism, and it does, from a pop psychology standpoint, but quite honestly, we hear so often of folks bandying about this term narcissism, or he's a narcissist, she's a narcissist. We hear that quite frequently. Folks use that quite regularly. Oh, I'm seeing, oh, look at this. Manipulation, selfish, charming, ex-husband. Monica, thank you for sharing that. We'll talk about that today too. Emotionally immature parent. Lori, thank you for sharing that. You're absolutely right. Self-focused, no empathy. Kurt, thank you for sharing that. Absolutely. Vulnerability and grandiosity. Absolutely. Emotional detachment. Yes, no doubt. Because what makes treating this personality disorder so difficult is that lack of empathy and compassion here that we're talking about. Oh, egocentric victim mentality. Yes, I think we are all on the same page here with this. But just a little history of where the term narcissism comes from. It actually comes from Greek mythology, from this Greek hunter named Narcissus, who he was so overly concerned with his physical appearance that he couldn't stop looking at himself as he stared in a reflection in the water. And he loved himself so much that he just sat there and did nothing but stare at himself until he passed away. And so that's where, and we'll talk more about the diagnostic criteria with this diagnosis, but also to how it's not just these narcissistic symptoms, but it also belies a very poor self-esteem and self-image and self-concept, which we'll dive into a little bit more here coming up. But yes, avoiding global labeling with this, I think it's so very important because, again, it's so easy to say, oh, you know what, they're a narcissist. Okay, but what does that mean clinically? And as with DSM-5 text revision, we have specific diagnostic criteria for narcissistic personality disorder that we can use as our guidelines for this. Now, you know how this works. There are 9 different diagnostic criteria for narcissistic personality disorder, and the client has to meet 5 of these. And y'all have already mentioned this in your comments here too, where, and I'm seeing self-loathing and low self-esteem too. Absolutely spot on, following up with what we were just talking about here. But I think first and foremost is that grandiose sense of self-importance, like really constant bragging and over-exaggerating their achievements. And I think, if again, speaking of the good Dr. Sigmund Freud talked a lot about overcompensation. And I think that with that low self-esteem and self-loathing we were just talking about, it really does lead to that overcompensation where it's okay, I am going to be grand, I am going to be grandiose, I am going to be larger than life, and everyone look at me and pay attention to me and really celebrate me. That, I think, is part of that grandiosity here. The second are frequent fantasies about having or deserving the best in life, having or deserving success, whatever that means to the individual, right? Power, intelligence, beauty, love, just having the feeling like they need to have the best of everything. And I'd like to hear from you guys too, as we're talking about all of these diagnostic criteria, and as we're talking about narcissism here today. I would love to hear, I used to ask my students this. I used to teach a social work program here in the area, and every time we would talk about these personality disorders, I would ask folks to think about, if you think about a public figure or a celebrity even that might fit some of these diagnostic criteria, please feel free to share, because I think that, or even your own personal experience with this, please feel free to share who you think may very well fit some of these narcissistic diagnostic criteria that we're talking about here for this personality disorder. Please feel free in the comments to share. But also too, number 3 here is a belief in superiority, believing that they are special or unique. And Hilda, I saw Trump. Yes, I think we have to be honest. And we'll see more as we talk about the diagnostic stuff here. We'll see more and more how that might fit Trump as well as others here. And it is very concerning with the narcissistic behaviors too. We'll speak more to this later. Oh, Joel, I see another Trump. And I'm not afraid to talk politics, by the way, but I do try to maintain professionalism and being civil here. And I saw Puff Daddy. Yes, it's P. Diddy, Puff Daddy. Is that, I forget, but yes, absolutely. Bonnie, a prior coworker, director of the city library at mid-sized city. Absolutely. You'll find that working with some of your coworkers, sometimes frequently management folks, yes, and Kurt saying Epstein, yes, I think that would certainly fit as well, no doubt, no doubt. Ex-husband, many famous people. Jennifer says many famous people. So do we create them or are they created? Great question. We'll talk about the etiology of this in a little bit. I think with that, we see that there is some biological components, but when it comes to the development of this disorder, but I think mostly it is environmental, and we'll get to that in just a little bit too. That's the Patrick Bateman. Yes, is it Patrick Bateman from the American Psycho novel? Am I getting that right? I think, yes, that was very eye-opening.
Yeah.
Absolutely. Is that correct, October? Is that right? Is that Patrick Bateman from? That's what I thought.
Yes. I believe so. And I was interested as we were looking up and doing.
Yes.
We were doing some research on individuals, like when we talked about this with personality disorder. It was interesting. I did not think this, but I don't know if you guys know Nick Cannon. You remember Nick Cannon?
Yes.
He revealed that he was clinically diagnosed with narcissistic personality disorder.
Yes, absolutely.
And
absolutely.
I wouldn't, you don't know that these people like in real life, you just see them. And I think somebody said it really well in the chat. Someone said they're charming. They're absolutely charming. And so
absolutely.
Yeah.
Absolutely. No doubt. No doubt. Very charming, very seductive. Absolutely. And yeah, I think that's another example here that we can use too, that grandiosity, that belief in superiority, the need for admiration, right? And like with celebrity, and this is why I bring this up too, because like with celebrities, for example, it's like I think, and we can't overgeneralize because I'm sure there are some exceptions, but I think from an environmental, social standpoint here, I think certainly what do? We do tend to put celebrities and public figures up on a pedestal, and we do tend to inflate their egos and such, right? From all this support and adoration that we give them. And folks who are living with narcissistic personality disorder really feed off of that. They have that need for admiration, but I think as we mentioned before, many have very fragile self-esteem and frequent self-doubt and a preoccupation with what other people think about them, especially the public. What are people saying about me on the comments? What are people saying about me here and there? And it's the overcompensation where it's all about me. It really belies that very fragile sense of self-esteem and self-worth and self-concept that they have such difficulty with. And those would be areas to focus on in treatment, which we'll get to that in just a second too. But number 5, a sense of entitlement. Absolutely. An inflated sense of self-worth, expecting favorable treatment, expecting special treatment. And what makes this, and we'll talk more about this too, but what makes this also so concerning is that they frequently become very angry when folks don't agree with them. And with that anger, especially in intimate partner violence situations, which we'll mention here more of in just a little bit, especially in those kind of situations, that could lead to definitely some conflict and definitely concerns therapeutically that we would have to look at, and safety concerns as well, which we will get to in just a second too. But number 6, a willingness to exploit others, to take advantage of situations, whether consciously or unconsciously, trying to get one over on other people, trying to get all the benefit that they can. And what too makes it so challenging, in my opinion, as a clinician, is that lack of empathy that we were just talking about, that lack of compassion. And y'all fully understand as providers, I hope anyway, that what empathy and compassion are. I think we learned that in kindergarten, do we not? That treating other people the way you want to be treated, and trying to put yourself in the other person's shoes, and just being mindful of trying to be kind. And we talk a lot about kindness nowadays too. And so that lack of empathy makes it so difficult to navigate this, because oftentimes folks dealing with this diagnosis will say things like, you know what, they should have known not to trust me, or they should have known this or that, and gaslighting and all those things, which we'll speak to in just a minute as well, no doubt, because I know y'all have heard about the term gaslighting. Absolutely. But it often, and I think I even saw this in one of the comments previously, often that with this lack of empathy, oftentimes they view feelings as weakness. And so you can very well imagine that with folks who are presenting with these type of symptoms, they don't often seek out treatment. And so they view feelings as a weakness. And what do we do as therapists? What do we do? We're always encouraging folks to talk about their feelings. We're obviously talking to people about opening up and discussing their emotions and using assertiveness skills and setting boundaries and all the wonderful things that we talk about in therapy. And folks dealing with these types of symptoms do not feel like they have a problem. I've been told numerous times over the years from clients that I've worked with this diagnosis is that everybody else is crazy, not me. They're the ones with the problem, not me. And as that's an area of concern for treatment, no doubt. Number 8, too, frequent envy. Being jealous of other people's success, belittling other people, or diminishing the achievements of others, all in the effort to make them feel better about themselves. And lastly is the arrogance, the patronizing behavior, talking down to others, being extremely condescending. That can absolutely be such a challenge in terms of how their interpersonal effectiveness with other people and how they communicate with others, particularly with partners and with family and friends and coworkers, which again, we'll speak more to that in just a second too. So I did mention a little bit earlier that with all of the diagnostic criteria that goes along with narcissistic personality disorder, narcissistic abuse obviously falls under this category, and there are numerous tactics that folks dealing with this diagnosis will utilize with their loved ones, friends, or coworkers, etc. And this is where we have to really start thinking about risk and lethality, even because, like we said earlier, when they become angry, it sometimes can lead to physical and emotional and mental abuse. And we have to be very mindful of safety planning when it comes to these types of issues. But some of the tactics that we see, even with folks dealing with NPD, would be, and you've probably heard about this one too, the love bombing. That is very much a very real thing where they shower the person with affection, all the attention, all of these compliments. But it really is a form of emotional manipulation to make folks feel over comfortable that, hey, I'm a safe person. Hey, I would never hurt you. And hey, I'm going to be validating to you. And I'm going to give you all of this love. And look at everything that I'm doing for you. So they'll give folks expensive gifts. They tend to tell people what they want to hear. And really, at the end of the day, it is all about emotional manipulation. Eric, you were also asking about gaslighting. And yes, that is probably the most common. There may be exceptions, but I would make the argument that gaslighting is probably the most common tactic that we see in narcissistic abuse, where, again, this is a form of emotional manipulation where they are trying to control, like we talk about here on the slide here with control and isolation. Folks are trying to control that person and manipulating them to make them feel unsure of themselves even. And if gaslighting, I think, really started becoming such a part of the public cultural lexicon here, where everyone started using this term, I believe around 2020, somewhere around there, if I'm remembering correctly. I think in 2022, Webster's Dictionary named gaslighting as the term of the year and are the word of the year. And I think it's really picked up steam with people really trying to understand it. So much of where it comes from absolutely fits. When we say gaslighting, its origins actually come from a play and an eventual movie in the 1940s called Gaslight, where a woman's manipulative husband would turn down the gas lamps in their home without telling her, and then he would dim them. She would bring it up and he would say, oh my gosh, no, you must be wrong. You must be forgetful. You must be imagining things. And then that would make her constantly question herself. And that is, at its core, that is what gaslighting is, to try to make people have self-doubt, to try to make them feel like they are the ones with the issues, not the person who is gaslighting them. So please give us some feedback on gaslighting in the comments too. Have you had experiences with clients in this regard? And we'll talk more about how to navigate that here in just a second too. But also too, another tactic that folks use with narcissistic abuse is withholding. And again, remember, so much of this is all about power and control. it's all about maintaining that leverage against the other person, right? Where it's like with withholding, they are literally trying to punish the person, whatever that means, whether it's withholding affection, whether it's withholding money and refusing to pay bills, whether it's not willing to openly communicate. So whatever it is that the person is withholding obviously can have a negative impact on people who are suffering from those types of interactions with these individuals. So please give us some feedback too on gaslighting, no doubt. And let me make sure we're getting all the other points here too. I think too, with the more getting back more to the clinical picture with the narcissistic personality disorder traits versus the actual diagnosis itself. I think in general, just anytime we're talking about making a diagnosis, utilizing DSM-5 text revision criteria, is that we have to be mindful that, okay, some folks may exhibit traits, but do they truly meet all of the diagnostic criteria to meet the full diagnosis? And that's definitely something to consider as well. And also, too, being mindful that there is some overlap with other diagnoses if we're doing some differential assessment here and trying to figure out, all right, what is really going on with this client diagnostically. I think so much of what we see would say borderline personality disorder or even bipolar disorder, especially in the manic phase of bipolar disorder. So much of that, so many folks will present with that grandiosity that we were talking about, that everything feeling so large and larger than life and just so exciting and so the best of everything. I think so much we see some overlap with that. And certainly looking at PTSD, looking at things through a PTSD or a trauma standpoint, absolutely. There are comorbid diagnoses that we see here with folks who are diagnosed with narcissistic personality disorder. Oftentimes they will have a trauma history from their childhood or even adulthood. Oftentimes they will have a comorbid, co-occurring substance use disorder. A lot of times they will turn to substances, alcohol, cocaine, for example, to really help them. If things don't turn out like they expect them to, that's where oftentimes they do turn to substances to help them feel better in those moments, or as I like to say, getting that dopamine hit that they're looking for. I think also in terms of diagnostically, as always, we have to rule out any sort of medical conditions that might be, before we make any kind of diagnosis, ruling out any kind of medical conditions that might present with these types of particular symptoms too. So I think that's just being a conscientious clinician in terms of trying to rule out everything else. And also too, just as an aside, with screening tools for things, definitely we've got to remember always assessing for safety and suicidality, because that can be an issue that folks with narcissistic personality disorder deal with too, especially if things don't go their way or if they have a more negative view of themselves or a negative self-concept. That can be certainly something we have to take into consideration. So doing any kind of like safety assessments, as always, as clinicians, that is so very important, as well as with co-occurring or comorbid diagnoses like depression and anxiety, which is very common. And we use tools like the PHQ-9 or the GAD-7 scale. The PHQ-9 is the patient health questionnaire. GAD-7 is the generalized anxiety disorder scale. So these disorders are co-occurring with narcissistic personality disorder. So we do have to be mindful of those as well.
I think, and Don, I think you brought up a really good point, because statistically, when you're looking at individuals who have narcissistic personality disorder, there is the co-occurring, like 14% of those individuals,
yes,
in studies have been shown to have alcohol use. 24% of those individuals misuse other drugs. And so
yes,
there's definitely, when you're talking about that doing substance use assessments is huge.
absolutely.
We have a little case here, and this is one thing I want to start with is, if you've known me for any period of time, I love research studies. That's what I read before bed. Most people read really nice novels, but my spouse reads like Game of Thrones and really wonderful. But no, not me. I like research studies. I like to see, because not all research studies are created equally. I can't stand to see ones that have 8 participants. I'm like, that's not really, I
Yes.
like really robust studies, but there have been some really good studies done. And one of the studies, and even the DSM-5 reports that like 75% of those that are diagnosed with narcissistic personality disorder are males. So it's a clinical phenomenon that it operates differently in men than it does women. But I think there's something that more people are considering is that vulnerable narcissism, and that tends to be more prevalent in females. And I think it might be something that's underdiagnosed.
Yes.
That's something that, but we're talking about in this situation, we have Jamie, who's a male client, and he walks into you in your office and he is exhausted and he's anxious and he is saying things like, maybe I feel like I'm being watched all the time. If I try to leave, they'll retaliate. So you're seeing someone here with all of these things that are clearly, this individual is in distress and they have panic and they have fear. And so there's a lot of things going on here. And when we did the poll of how many of you have ever worked with someone who felt trapped in a relationship, I saw the poll results. It was bouncing between 95 to 97%. I think we landed on 96.
Absolutely. Absolutely.
So obviously, you guys have had some good, I would say some experience. Let's say that. Some experience.
October, I totally agree with that. And I think too, I mean, just being honest, I've had 20 plus years of experience in the mental health field. And I think quite honestly, most of when I'm working with folks, when we're talking about narcissism, it's not the person that probably needs to be in therapy. It's because a lot what we say earlier is folks dealing with this diagnosis is they don't feel like they need treatment. So oftentimes it is underreported. Oftentimes folks who need treatment are not there, but certainly we as clinicians are going to be working with the individuals who have suffered because of the person dealing with this diagnosis. And that's where most of my clinical experience has come from with this. And Guadalupe, I see your question too. What percentage is males? I think with what October was saying, and I think the numbers wise, obviously it affects more males. I think the numbers are all over the place, anywhere from 50 to 75% of folks who are diagnosed with narcissistic personality disorder. And DSM says it's about 0.5% of the population. I think that's probably underreported, like October was saying. So it's because, again, folks are feeling like they don't need treatment and journalizing it and projecting it, as we say, onto everybody else has got the issue, not me. So October, I'm sorry, I cut you off. I just want to throw that in there.
No, you're absolutely right. No, you did not cut me off at all. That's exactly what is going on. And it's sometimes, and I've heard this mentioned and in circles, and one thing is, in being the chief clinical officer at ICANotes, I have the opportunity of getting to work with clinicians from all over the United States, all in different types of practices, right? And inpatient settings and outpatient settings. And I love that opportunity. And I will have to tell you, in conversations that I've had with individuals, it's almost, listen, there's not a lot of evidence there. So I want to be very clear before I make this statement. Okay. Was evidence-based information? There's not, but I think there is a clinical consensus that it suggests that, like, prolonged exposure to this narcissistic abuse, like whether it's informative relationships, whether it's intimate relationships. I heard people in the chat saying, look, it's my ex, it's my coworkers, especially when your coworkers, sometimes you're with your coworkers more than you are with your spouse. So it can absolutely be damaging. But there is this prolonged exposure to narcissistic abuse maybe can contribute to some of this traits in borderline personality disorder.
Yes, totally agree. Totally agree. And if I might piggyback off of that a little bit, because Eric is making an excellent point here. He says it would be shocking to get an actual narcissist to go in for an evaluation. I think based off of my clinical experience with this, Eric, I would certainly agree with that. I think, October, you and I used to work on an adult inpatient unit for a behavioral health hospital in the Charlotte area. And I think please feel free to add to this as well. But I think a lot of times most commonly I would come across patients dealing with narcissistic personality disorder on like an inpatient setting, and a lot of times truly that honestly was because of being involuntarily committed. And they're, yep, you just said it, being court ordered. Yes, they were involuntarily committed to show up to the inpatient unit for whatever reasons, whether it was some kind of domestic violence, intimate partner violence situation, whether it was breaking the law in some ways. Because again, remember, they feel like they deserve to have the best of everything. So inevitably that could lead to breaking the law and things like that. And being court ordered for outpatient treatment, which by the way, isn't always a guarantee that they're going to actually do it unless the judge says, hey, look, if you don't show up, you're going to go to jail. So, and even when they do show up, it can be quite difficult because I've literally had people say to me, hey, I'm just checking off a box here. And I just got to be here because they tell me I've got to be here. And in my opinion, that doesn't really lead to any good clinical outcomes if they don't have an inherent motivation to better themselves in treatment.
Absolutely. No, so well said. I'm going to move over to the formulation list when you're dealing with individuals and predispositioning, like the family. One of the things I could say, statistically, up to 40% of individuals with narcissistic personality disorder, they do report adverse childhood experiences. So we know that. Is there a trauma history involved there? Also precipitating, this would be like separation planning, like we're talking breakups, perceived rejection, right? Perceived, it doesn't even have to be real, are some of those common triggers for narcissistic rage and the escalation and perpetuating, I think, intermittent reinforcement, the shame and blame cycle. I think this, and it's validated, this intermittent patterns, they reinforce those trauma bonds and they just prolong the distress in victims. So you just have this prolonging. For protective, we were talking about sibling support when we were talking the case of Jamie. One of the things is that, and this is proven, that and everybody knows this, so I'm not saying anything that you probably won't all agree with, but very strong social ties reduce the relapse of trauma-related symptoms by 30%. So
I would absolutely agree with that. I think we all know that having a strong social support network is so very helpful. And I think therapeutically too, it can be helpful because what we're just talking about with gaslighting and love bombing and all those things, it may very well make that patient's loved ones feel so uncertain, which is the whole point, by the way. And it is coercive. It is about power and control. And so a lot of times working with my clients who have a loved one dealing with narcissistic personality disorder, we would have these conversations where it would be like, hey, let's do some reality testing techniques even. Okay, because when folks say gaslighting, what are some examples? I made some notes here. What are some examples of this? Oh, you really are overly emotional, or it really didn't happen that way. Or my favorite, I'm sorry that you got mad. Is that really an apology? No, it's not. And it's those kind of things that really, the constant gaslighting that makes their loved ones feel so uncertain and making them feel like they're the ones with all the problems when in fact they're not. And so from a reality testing standpoint, I always ask my folks, all right, you're having these thoughts and feelings. What evidence do we have of that? What verifiable, certifiable proof do we have that this has indeed happened? And by the way, as y'all have probably used this too, I've asked folks to say, hey, think about somebody that you love and trust in your social network. And look, what would your best friend say about this particular situation? What would be their feedback? And sometimes using those reality-based type of techniques, I call it the reality testing stuff that we do, I think it can be very helpful in helping folks who are dealing with narcissists to really manage it better and to really help them focus more on setting very firm, consistent boundaries.
Absolutely. So what's that?
Oh, speaking of which, boundaries.
Right?
Yes.
Right. Exactly. Leads us right into
absolutely. Absolutely. And I know too, every time and again, most of my experience with this has been from loved ones who are dealing with someone living with narcissistic personality disorder. So it's a lot of it really is to, making sure we've got structure in the session, making sure we've got goals. Y'all know this, goal-oriented type interventions, like focusing on the goals. What would be the goals? Really helping your client figure out what exactly is it that you want from all this. Do you want to figure out how to set those boundaries like we were just talking about? Do you want to figure out how to leave the relationship, and we have to take all the safety considerations into mind too, of course. So it's like really helping your client figure out what it is that they want to work on in the session. And of course, too, making sure that you set very firm administrative boundaries too. Now, I have worked with a person or two living with narcissistic personality disorder over the years, and it is making sure you are firm and consistent, because like with no-show and cancellation policies, late arrivals, if they want any kind of documentation for court, or if I'm subpoenaed for court for whatever reason, making sure from the get-go that I'm very clear about what the boundaries are, what my professional expectations are, and making sure as many of you, I'm sure, have your own professional disclosure statement, and that's where you would clearly delineate what your late cancellation or no-show policies would be for late arrivals, for court appearances, those kind of things. So it's like just making sure that you've got those administrative boundaries set in place, because like we said, they will absolutely try to manipulate us as well. So we have to be very firm in terms of what kind of boundaries we're going to set. And as well with the between session contact, because that is very much a thing too. I do keep in touch with some of my clients between sessions, and that inevitably happens when things do come up. I do try to help navigate those things, but I rarely ever try to do any kind of crisis management by emails or messages. I really would prefer clients to come in and let's talk about face-to-face or through telehealth too, having some kind of contact or some kind of one-on-one communication with that. So just making sure we're setting some very firm boundaries with that. And then the legality of it all. Inevitably, we talk about records. Inevitably, we talk about which October is going to be talking about progress notes and documentation here in just a second too. But if I can give any advice, is, as everybody knows, I always say, hey, I don't make the news, I just report it. That's an old saying from journalists, right? Where I don't make the news, I just report it. It's the same kind of concept here. It is not for us, especially with any kind of legal situation, court custody, intimate partner violence, domestic violence, separations, divorces, etc. Inevitably, your clients are going to say, hey, I need my therapist to show up in court for me. And with that, I would say boundaries wise, making sure you're very clear about what your subpoena court appearance policy would be. Mine is expensive. So I'm very clear that if you do want me to come to court, then you're going to have to pay me for that, because there are many reasons for that. One is that when I am spending most of my day in court, which it does tend to end up being most of your day, then you have to make sure that you're being compensated for your time, because everybody knows that your time is valuable and you got to make sure that you're being compensated for it. So just making sure you're clear about what those type of financial expectations are, as well as release of records. Now with subpoenas, and I know it differs in different places, in different states and such, it can be very different, but so many things remain the same. And that in general, I am not a fan of releasing progress notes to my clients. I think especially for clients living with narcissistic personality disorder, because what do we do in our initial assessments? What do we do in the mental status examinations that we were talking about earlier? If you do a mental status, what's on the mental status? Oh, client presents with limited insight. Client presents with poor judgment. Client presents as what? Disheveled. Client exhibits disorganized thinking or a tangential thought process, or their mood is very labile, their speech is very pressured, etc., etc., etc. Any of those things can be a perceived criticism from a person dealing with narcissistic personality disorder. And I'm very mindful that I'm not really trying to not release those notes to them, because they will try to find things to kind of complain about, if we're just being honest. And so I'm very careful with that. And just in general, releasing progress notes to anybody at all. Generally, unless it's a court order coming from the judge, I usually do not say, hey, here are my progress notes. Please feel free to have everything you need. I'm very protective with those kind of things for just all the reasons that I mentioned, but especially with HIPAA and patient confidentiality too. No doubt. No
I
doubt.
definitely, and with the new Information Blocking and Cures Act, it's not that new anymore, but when
Right.
that came out, when they have to have access, that I tell people to make sure and try to protect your psychotherapy notes can be
Mm-hmm.
private. And so, and there are three
Sure.
ways you don't have to release notes for three reasons. One, if it could cause harm to the patient.
Yes.
You do not have to release note. You do not have to release psychotherapy notes, which again, you would want to keep those kind of private. And then also, if it is something that is involved in a criminal or civil case, you do not have to release the note. So that is, so you have the 3-note exceptions there. I know, Don, we are on time. I was wondering if we can, you have so much good information, but we are at.
You're telling me to be quiet now.
No,
Or,
I'm
yes,
not.
I can do that.
No, I'm absolutely not. I would never say
No,
something.
I get it. No, you got things you've got to get to as well, October. I totally agree with that. So
No, but I think some of these, you tell me which ones you want to, which are the most important ones to head over. I think you talked about boundary really well, and you did really well about talking about, listen, I'm the chief clinical and compliance officer for ICANotes. And one thing I will tell clinicians all day long is that your paperwork, your informed consents, your right to treat, all of those, your legal paperwork will make or break you in a lawsuit. And I say that because I did work for a law firm. We protected mental health clinicians. And so I've just seen that. So make sure your paperwork is in order. Do not try to chat GPT your forms. Okay, I see people do that all the time. Do not do that. Do not do that. Make sure that you have legal good forms from a good source. Even if you have to pay a little bit of money for them, it is worth it I promise you it'll be worth it. Okay.
Absolutely. I totally agree with that. And October, bringing up Chat GPT and AI and the use of AI and things like that, that might be a future webinar topic that we can get into. I have many thoughts about that. So yes, I would love to. Let's put that on the list. Why not? No, I think we've covered so much of the boundary scripts already and talking about boundaries, but the professional and the ethical boundaries, and especially with like our professional disclosure statements and our protecting ourselves as clinicians, making sure that we're doing everything we need to do. I think too with progress notes, I always used to tell my students, you know what, you don't have to make it war and peace. Let's try to keep things general. Let's maybe not try to go into all of the specifics, because I think that we want to make sure we're documenting what exactly happened in the session, but let's also not overshare, so to speak, because that can be problematic too.
Absolutely. Treatment planning. Kurt says, how can you avoid releasing notes? Though you can't. That's one problematic. It's got to be one of those 3 reasons that I talked about, Kurt. It's a really good question. But what you can do, and what I would do, especially if you have someone with personality disorder that's called you and they want their notes, if there's something in the notes you think is going to hurt their feelings, you say, hey, can we go over the notes together? I'd love to sit down and go over the notes with you and talk about that.
Absolutely.
That might save you some problems down the road as well. So
absolutely. Sure. And I've done that before, October. And you know what, I will say too, depending on what it is that they need, because the needs they vary, obviously, but sometimes it really can be so simple as, if I've got a client for whatever reason is involved in any kind of court thing, whether it's narcissistic personality disorder or otherwise, usually what I'll say is, okay, it would be expensive if I have to show up in court. And by the way, who wants to spend their whole day in court? That's just my personal feelings on that. But who wants to do all that? So if you can avoid that, it just could potentially open us up to so much potential liability. So all of those things do tend to make me nervous, as I think everyone may feel that as well. So usually if it can be helpful in any sort of way, I'll recommend, hey, I can write a statement for you. I would be glad to write a very general, to whom it may concern letter. Hey, so-and-so is under my care. So-and-so has been diagnosed with this particular diagnosis, and we started treatment on this day, and we continue to see each other every week, and just keep trying to keep it as general as you can. That would be my absolute number one recommendation with this.
Absolutely. Oh, that's great. That's really great. You're talking about stabilization, and then we were go through like skills and autonomy for people and then also trauma processing. I know there's EMDR in there. I know you're a huge fan of that as well.
Yes.
What are some things as we look at stabilization and skills and autonomy and trauma processing? What are some things? And I'd love to hear from the audience too. Like, what are some things that you like to do?
Absolutely. Absolutely. If we could go back to
Yeah.
phase one real quick,
Yeah.
October, if you don't mind. Yeah, psychoeducation. Y'all, psychoeducation, I think it's so very important. And I think it hasn't always been received well. Sometimes I will sit with clients and go through the DSM diagnostic criteria with them and say, hey, this is our manual for mental illness. This is how we make our diagnosis. These are the diagnostic criteria. This is the time frame. This is the number of symptoms you need to meet. And it's like really giving yourself permission to have an open, honest, assertive conversation with folks about what your clinical opinion is on this and why it is that you feel like they meet many of the diagnostic criteria for narcissistic personality disorder. So yes, like I said, sometimes that can not be met with positive feedback, but I think that it's very important for us to have those very assertive conversations with folks and being honest and open about what our feelings are about their clinical picture here. But always, a safety planning is always so very important here. Looking at, and I'm sure y'all have done safety plans and you know what that looks like, but we have to plan it for suicidality, but also for any potential risk for any type of harm from the person who is dealing with narcissistic personality disorder too. So that's something I think to be mindful of as well. And also too, I think it's always mindful to be aware as clinicians, mental health therapists, for example. Yes, we're not medication providers, but I used to always tell my students, it is so very important for you to be familiar with what type of medications that your clients are on and and how long they've been on it, what type of medicine it is, and recognizing too, like if a client says, I'm on fluoxetine 20 milligrams, we got to know, I think it's our responsibility to know that's Prozac and that is used to treat depression and anxiety. And as we said earlier, the comorbid or co-occurring diagnoses that often go along with narcissistic personality disorder are depression, anxiety, even substance use disorders, and those kind of things. So we have to be very mindful of that as well. In October, what is it? I'm sorry, what were you
I
going to
got a
say?
question. Sorry about what.
Yes.
Could you please repeat the three types of notes that don't have to release?
Oh,
Absolutely.
yes.
It is psychotherapy notes. And listen, it's a really narrow term there, but it is, they don't have to be released, psychotherapy notes. Then any kind of note that has information in it that is about litigation, okay, of any kind or any kind of legal proceedings. It doesn't matter what it is on. And so you don't, if it's for criminal or civil, you don't have to release that note. There's also like notes that you don't need. Just there's certain note types, but it's called a non-portal note type or confidential non-portal if that's something used by like a medical student note, something like that. That's not something that you're going to come in contact with. I don't believe. So I don't believe. And like messages between staff, unless it's converted into a clinical note, it's a message between staff. You don't have to release that. Unless an attorney subpoenas everything. Okay, that's different. Subpoena is different than releasing notes. But yeah, but if it's a psychotherapy note or if it's a note that could cause harm. And harm, there's a term there with harm. It could be something like the patient might see this note and harm themselves, worried about, so I want to talk to them about it. It also could be like, let's pretend someone is in a relationship with a narcissistic person. And that narcissistic person has access to their email and their portal, has access to their phone. And you have been talking with this particular patient about this narcissistic personality disorder in their life and how they're like, basically there's violence going on and abuse and torture, all of the things. And you're scared that this person with narcissistic personality disorder will get into your client's portal and see those notes. You can't guarantee the safety. That would be rolled up into home. You could attest to that and say, you know what, I didn't want to release their notes to them, or unless I was talking to them directly, because I'm scared they're being coerced and those notes, they'd be forced into sharing those notes. And we've had these really kind of private conversations. So you could, from that aspect, you have to think about it from that angle. Could that cause harm? Sure.
Absolutely. Absolutely. I just love the comments. I love the questions. I think this is great. I know we're limited with just an hour-long webinar, but you've done so great with this. Thank you for all your comments. October, I just need 2 minutes real quick, and then I'll be
Go
quiet
for it,
because I know you got to get
please.
to your stuff too.
No,
But
no,
maybe this will be the last thing I'll throw out there. And then any questions, of course, you guys please feel free to reach out to us as always. I will say, I think I saw a comment or a question a while ago too. Is narcissistic personality disorder the result of nature or is it nurture? So basically, are we talking biology or are we talking social environment? And I think this, I think, quite honestly, all the experts really aren't sure. I think there is a bit of a genetic component. There's some evidence that it could run in families, especially with close relatives, and like neural pathways of the brain may be a tad different in a person diagnosed with this disorder. But I think too, most of what we see, we could probably make this argument that it is social. It is social learning. It is observation. As children, these folks will sometimes observe and imitate, and they learn narcissistic traits from other people, usually family members that they're exposed to. And even more from the social environment aspect of it is that these clients experience negative childhood trauma, rejection, neglect, a lack of support. There are a variety of different contributing factors to this. And also, too, we have to look at parenting style. If a parent is that helicopter parent and they are overindulging the kids, and if they're very overprotective with the kids, these folks, when they grow into adulthood, they might expect this continued treatment, this wonderful red carpet treatment as adults. And when they don't get it, or when things don't go their way, they have a difficult time regulating their emotions, and which leads them to having a difficult time with their behaviors and their relationships with others. And that's all I'll say to that. October, your turn.
No, you did great. I actually threw up another poll question that we had. I was
Yes.
These poll questions like loaded in. So I'm going to go through these slides because we do give you the handouts. So I want to talk about really quickly going through the slides, like the skills and autonomy. I think you did a great job with that. Trauma processing, relapse prevention. I think we should do a round 2 where we go through and talk about these things some more. One of the things we're going to talk about is documentation, the progress note, and documenting risk. I'm going to take you through that and what you should be documenting. We had kind of sample phrases in here. I'm going to do an ICANotes walkthrough. I'm going to do that very quickly within 3 minutes, and then some downloadables, and then ethics and reminders. I think you did a really good job talking about that, about subpoenas and court involvement and things like that. Because that's one thing we heard, and Don said a couple of times, that clinicians got to get pulled into. If people do seek therapy with NPD, it could be for like a secondary gain issue. Maybe like they're taking people to court and they need someone to side with them. So I've heard a bit of that. I do want to talk about our poll results a little bit. I said, how many of you have ever? How many of you have ever worked with someone who felt trapped in a relationship, even though there wasn't overt violence? 95% said yes. And I said, in your clinical opinion, could prolonged exposure to a partner with NPD contribute to development or exacerbation of BPD traits in another individual? 96% of you said yes. So that was really interesting on that. So definitely thank you so much for sharing that. I am going to take you through ICANotes. We're going to do a note on someone who has NPD. So I'll just be sharing my screen really quickly here. You can see. Here's ICANotes. Many of you are ICANotes customers in here today. And if you're seeing this, thank you so much, Claire. You're awesome.
Thanks, Claire.
But if you're seeing this, you're like, that's not what my ICANotes looks like. You are on the classic version. This is the plus version. Everybody will be moving to the plus version, but it is a lot different. It has a very nice dashboard. It has a calendar that has a portal scheduling link in there. So you can put that right on your website. People could schedule into your calendar. It, of course, does text messaging reminders. But I'm just going to hop into a patient's chart here. This is Jenny Newman's chart. And what I'm going to say, even our active problem list, there's a personality disorder. But I'm going to go through a progress note because, like, I'm seeing her today, and I'm going to say that she has symptoms of, and then we'll go to personality disorders, and then we have narcissistic, and then all of the things like lack that we talked about today, lacks empathy, needs reassurance, partner is that's one thing. The problems are unique. Right? They're entitled. They exaggerate their talents. They exploit people, maybe outbursts. Things like that, self-importance, uses charm. One of the things I really like about ICANotes is if there are some things that I want to take off, let's say here in content mode, let's say that I don't see people with DHD or oppositional defiant disorder or reactive disorder. I took that off my list, but maybe I don't see folks with psychosis. Let's just say that. You can remove that. I can also add custom content here. So this, once you do it in one place, it stays in every chart. So I'm just going to say custom content or customer content stay. Fine. There, and save. And then I can take this to the very top of the list. And then that is my content mode. You'll see it's there. So I like that. And I think it's really helpful. You also have custom buttons on the right-hand side, but then I can say in their behavior, I could go through and talk about their behavior, that maybe their substance use is more than advised, and there's been anger, and that's poorly controlled, and their impulses are partly controlled. And I could say that their functioning work has been impaired. And then if they have an MSE, a mental status exam, and it's normal, I can hit normal, and that will populate in there. One thing, as you see here, you're probably like, October, what is this? This is ambient scribe. So we do have an ambient scribe in ICANotes. We call it is clinically humble, and it makes sure that the clinician sounds good during the note, that everything that you talked about as far as coping skills and support and all of those things are very well documented. So I personally think our ambient scribe is better than all the other ones, but that's because I helped create it. So I am a little bit biased, but I do think it's great. Thank you so much, Lori. And so we're able to put all these things. I can talk about suicide violence risk. I can justify level of care, like suicide risk assessment. I'm going to say that they're not suicidal at all. Justify level of care. I can put that in the history and say that outpatient is still needed because it interferes with their day-to-day activity and they require continued treatment. I can even go into, as you can see, we have play therapy, we have EMDR, but I can go in and link in my treatment plan, and I can pull up a narcissistic personality disorder. I can select from the list. I can select my interventions if I have them in there and drop them straight in. And then I can link that treatment plan right in. So it looks like what did not take me a long time at all. I have compiled a very nice note and dropped in the treatment plan on this person with narcissistic personality disorder. So yes. That's ICANotes. Ambient listening, I just click the button, whether you're doing telehealth or in-person sessions, it will record it. Let me tell you how our ambient listening is a little bit different. I like to listen to clinicians. You guys know that. So we're developing things. And one of the things I heard people really fuss about with other ambient scribes was that it keeps the recording. And sometimes that can be a nightmare. Like you really don't want that recording. I'll be really honest with you. Again, worked for a law firm for a long time. So you don't want that recording. So what we do is you don't get the recording of the session. What you do get is a transcript. But once you create the note from that transcript, and that transcript goes away in 2 or 3 days. So that way you have your note. And then if you ever get in a liability situation, that note is what you have, and it is a good note. They cannot go back and listen to a recording because everybody has their own opinions about how they treat people. And same with the transcript, those things disappear. So that's basically it as far as ICANotes. I want to thank you guys so much for coming to the webinar today. We love putting on these webinars. If you have other things that you please, like webinars you'd like to attend, please drop them in. I tell you what, I stopped doing the information blocking webinar because it's been out for a little bit. In the beginning, when it came out, clinicians were really flustered about note sharing, and I get it. I'm the same way as Don, especially mental health. And what I will tell you is they did studies on every other discipline, but they did not do them on mental health. Okay. And when they asked about note sharing is different for mental health. You don't really want to share your notes. It's not an orthopedic visit. It's not a stuffy nose like I have right now, go to the doctor. And they said, we did it for pediatric oncology and it seemed to work well. It's like, not the same, not the same. Again, good studies weren't done on note sharing. But I'd be happy to do information blocking because I like to keep people legal. And there's different states that have different rules among the federal rulings. So we could go over that if that's something people are interested in.
Absolutely.
And so, well, thank you, Darlene. And thank you, everyone. And Don, thank you. Amazing.
Thank you, October. It's always good hanging out with you. And look, everybody, thank you so much for your feedback and your questions. And please reach out if you've got any other questions or concerns or any for future webinars. Please let us know. It was great hanging out with y'all today. And please, thank you to everyone for all of the great work that you're doing out there. Please, as I always like to say, let's keep hope alive, and let's please keep moving forward and just continuing to take good care of your clients and taking good care of yourselves. Thank you for being here today. Keep up the great work.
Bye.
Bye-bye, y'all.